السلام عليكم دكتورة فاطمة. Can we start?
Yeah, sure.
Please.
Good afternoon, everyone. For today, I'm going to present the partner trials. Well, those trials have been published by the New England Journal of Medicine, and they were sponsored by the Edwards Life Sciences. So first of all, I'm going to start with the cohort B and partner 1. With the title Transcatheter Aortic Valve Implantation for Aortic Stenosis in Patients Who Cannot Undergo Surgery. So as a background information, aortic stenosis is an insidious disease with a long latency period followed by rapid progression after the appearance of symptoms, resulting in a high rate of death among untreated patients. Surgical replacement of the aortic valve reduces symptoms and improves survival in patients with aortic stenosis, and in the absence of serious existing conditions, the procedure is associated with low operative mortality. However, in clinical practice, at least 30% of patients with severe symptomatic aortic stenosis do not undergo surgery for replacement of the aortic valve, owing to advanced age, left ventricular dysfunction, or the presence of multiple existing conditions. For these patients who are at high surgical risk, a less invasive treatment may be a worthwhile alternative. All the previous studies of TAVI have been observational registry studies without standardization of endpoint definitions and without control populations. And there were a paucity of rigorous evidence-based clinical data to substantiate the incremental benefits of TAVI. So the aim or the purpose of cohort B, partner 1, was to report the outcomes with TAVI as compared with the standard therapy among the patients with severe aortic stenosis who are not suitable candidates for surgery. So initially, the investigators and the executive committee has recruited or screened around 3,105 patients, and out of those patients, they enrolled around 1,058 patients into 2 different parallel trials. Starting with parallel 1, which was the cohort A, I'm going to talk about it furtherly. They involved from the 1,058 patients, around 700 patients. They were divided into 2 subsequent groups. The first one for the patients who underwent TAVI with a transfemoral approach versus surgical replacement of aortic valve. And the other group was the patients who underwent TAVI with transapical approach versus surgical aortic valve replacement. In cohort B, they involve the remaining of the patients from the 1,000, the 358 patients, and they were also divided furtherly into 2 groups. The first group after randomization was the TAVI with the transfemoral approach for all the patients versus the standard therapy with balloon valvuloplasty. So the study design for partner 1 cohort B was a prospective multi-center randomized clinical trial. It involved around 358 patients randomized in a 1-to-1 ratio into TAVI with 179 patients versus standard therapy, also 179 patients. It involved patients from different centers, around 21 centers, and 17 of which were in the United States. The study was conducted starting from May 2007 till March 2009, and all the patients were followed for at least 1 year with a median follow-up 1 year and 6 months. And they had the primary outcomes of all-cause mortality, basically. The secondary outcomes were rate of death from cardiovascular causes, New York Heart Association functional class, rate of repeat hospitalization, distance covered during a 6-minute walk test, valve performance assessed by echocardiography, rates of myocardial infarction, stroke, acute kidney injury, vascular complications, and bleeding. So the inclusion criteria, they included the patients who had severe aortic stenosis as defined by any of the following: aortic valve area of less than 0.8, aortic valve area index of less than 0.5, and mean aortic valve gradient of at least 40, and peak aortic jet velocity of at least 4. New York Heart Association, the patient should be symptomatic with a grade 2 at least, and the patients who were poor surgical candidate by any of the following: an STS score of 10% or more, coexisting conditions with at least 15%, probability of 30-day post-op risk of death, and coexisting conditions which would also predict an at least 50% 30-day post-op risk of death or a serious irreversible condition. The exclusion criteria was about the patient who had a bicuspid or non-calcified aortic valve, acute myocardial infarction, substantial coronary artery disease requiring revascularization, left ventricular ejection fraction of less than 20%, a diameter of the aortic annulus of less than 18 or more than 25 millimeters, a severe mitral or aortic regurgitation, starting from grade 3 and above, a transient ischemic attack or stroke within the previous 6 months, and severe renal insufficiency. Well, starting with the intervention for cohort B, partner 1, patients who were assigned to TAVI group, they had a femoral artery approach and percutaneous placement of a tri-leaflet puvine valve with a stainless steel support frame deployed by balloon during rapid RV pacing. The heparin was used very procedurally, and aspirin and clopidogrel were continued for 6 months. They used the Edward Sabian first generation valve, and the patients who were assigned to the standard therapy, they underwent usual therapy as directed by the treatment team. The baseline characteristics for the patient in the two groups, the TAVI and the standard therapy, generally were well balanced. Regarding the primary outcomes, while comparing the standard therapy versus the TAVI group at 1 year after about 12 months, we will see that the rate of death from any cause was higher in the standard therapy group, and it was statistically significant with a p-value of 0.001, less than 0.001. Looking at B, also we have a lower rate of death from cardiovascular causes in the TAVI group, also the statistically significant difference in comparison to the standard therapy group. Also the rate of death from any cause or repeat hospitalization at 1 year was also lower in the TAVI group with a statistically significant difference. And also the death from any cause of or a major stroke was also lower in the TAVI group. So the primary outcome, TAVI was associated with lower rates of all-cause mortality at 1 year, as well as the composite endpoint of all-cause mortality or repeat hospitalization for valve or procedure-related deterioration at 1 year, in comparison to the standard therapy group. Here we can compare the two groups, the TAVI versus the standard therapy, also at an interval of 30 days. If you can see here, the vascular complications were at 30 days, where the rate was much more higher in the TAVI group, with a statistically significant difference of less than 0.001. And also the acute kidney injury, if you can see here, was also higher in the TAVI group. Regarding the symptoms, which considered as the secondary outcome, we can see at 1 year interval in the TAVI group, the symptoms were much reduced regarding the fourth New York Heart Association class in comparison to the fourth degree of New York Heart Association symptoms and the standard group with a statistically significant difference. So for the secondary outcomes, the 6-minute walk test could be performed in only a subgroup of patients owing to the presence of pre-existing conditions in many of the patients. At 1 year, a paired analysis of the distance covered during a 6-minute walk test showed that there was a significant improvement after TAVI and no change after the standard therapy. In conclusion, in patients with severe aortic stenosis who are not suitable candidates for surgery, TAVI, as compared to the standard therapy, significantly reduced the rates of death from any cause, the composite endpoint of death from any cause or repeat hospitalization, and cardiac symptoms, despite the higher incidence of major strokes and major vascular events. Partner one had some study limitations. They excluded specific groups that would likely benefit from the procedure, including those with coronary artery disease, severe peripheral vascular disease, and a patient who had a reduced ejection fraction, less than 20%. They had a limited follow-up to evaluate for the duration of benefit, and there was unknown durability of the valves which were used in the TAVI group, and unclear cost effectiveness also. Now I'm going to discuss the second part of partner one, which is cohort A. So this part was presented with the title transcatheter versus surgical aortic valve replacement in high-risk patients rather than in operable patients in cohort B. So the study was conducted with the question that in patients with severe aortic stenosis who are at high surgical risk with expected periprocedural mortality of around 15%, is transcatheter aortic valve implantation is non-inferior to surgical aortic valve replacement with regard to all-cause mortality. So the study design was also prospective, multi-center, randomized, open-label, comparative clinical trial. They involved around 700 patients, randomized in a 1-to-1 ratio to TAVI and surgical group. Also, they involved patients from different 25 centers in different countries, and the study was also conducted starting from 2007 to 2009 with a median follow-up of 1.4 years, and the primary outcome was also all-cause mortality at 1 year. Secondary outcomes were also similar to the partner cohort B: death from cardiovascular causes, New York Heart Association functional class, repeat hospitalization, MI, stroke, acute kidney injury, vascular complications, bleeding, 6-minute walk distance, and valve performance. The inclusion criteria was also similar to the cohort B trial, except for the fact that they included the patients who were at high risk for undergoing aortic valve replacement rather than the patients who are considered inoperable. The exclusion criteria was also similar to cohort B partner one. The intervention at enrollment, patients underwent mapping or vascular scanning to determine candidacy for transfemoral versus transapical TAVI approach. Then subjects underwent 1-to-1 randomization stratified by planned approach, transfemoral versus transapical, and they were divided into TAVI and patients with high risk for undergoing aortic valve replacement. Also, the heparin was used procedurally, and the aspirin and clopidogrel were continued for 6 months, and the major outcomes were followed for different time intervals. Baseline characteristics between the two groups, the patients in the transcatheter approach and the surgical replacement, were generally balanced and equal. So now comparing the outcomes at different intervals, we have here at 30 days and at 1 year. Starting to compare the transcatheter versus surgery in high-risk patient regarding the point of death, we can see here that higher rate of death was noted in the surgery group without a statistically significant difference. We had a p-value of 0.07. The vascular complications were much higher in the transcatheter approach, with a statistically significant difference, which was less than 0.001 at 30 days interval. Also, the major bleeding was noted in more in the surgical group, and also the new-onset atrial fibrillation the rate was also higher in the surgical group with a statistically significant difference. Okay, now the primary outcome, which was monitored at 1 year, most importantly, which is the median follow-up time for those patients. Okay, comparing the transcatheter versus the surgical groups regarding death from any cause and all patients, there was no significant difference between the mortality at 1 year, and also when they noticed death from any cause through transfemoral placement cohort. As I indicated earlier, that they had two approaches, the transapical and transfemoral. Even when they divided the approach and compared only the patients who underwent the transfemoral approach to the surgery, they didn't have a significant difference in the rate of death in the two groups. So at 1 year, the primary endpoint of all-cause mortality was 2% lower in the TAVI group, meeting pre-specified criteria for the non-inferiority. Okay, so now the secondary outcomes. At 1 year, we have more reduction of the symptoms in patients who underwent TAVI in comparison to the patients who underwent the aortic surgical replacement. Echocardiographic findings, aortic valve gradients and areas improved significantly after the two procedures at both 30 days interval and 1 year. And at 1 year, transcatheter replacement was slightly superior to surgical replacement with respect to the mean aortic valve gradient and area. However, moderate or severe paravalvular regurgitation was more frequent in transcatheter group than in surgical group at 30 days interval. So as a conclusion, in patients with symptomatic severe aortic stenosis or at high risk surgical candidates, TAVI was associated with a similar all-cause mortality to surgical aortic valve replacement at 1 year. So they concluded that TAVI is non-inferior to surgery in terms of mortality in high-risk surgical patients. Study limitations. The withdrawal and decisions to forego the procedure among patients who were assigned to undergo surgical replacement were unexpectedly frequent. A second, a definitive assessment of the durability of the prosthetic valves used in transcatheter replacement awaits longer follow-up. We need longer follow-up in both cohort B and A. And finally, the study had insufficient statistical power to reach robust conclusions with respect to specific subgroups of patients. As you noticed, that the number of the patients and the who were randomized was a little bit reduced, not like the other trials who involved a higher number of patients. So for now, I'm going to discuss the Partner 2 trial. This study was published with the title Transcatheter or Surgical Aortic Valve Replacement, now in intermediate risk patients. So the clinical question for the study was in patients with symptomatic severe aortic stenosis who are intermediate risk surgical candidates. The expected risk was around 4 to 8% of mortality. Is transcatheter aortic valve implantation non-inferior to surgical replacement with regard to all-cause mortality and disabling stroke? Initially, they also screened like around and involved 2,032 patients. And then they divided the patients according to the approach also used in the TAVI group to transfemoral and transapical or transaortic approach, and then one-to-one randomization into TAVI or surgical group for each trial. So the trial incorporated two parallel studies, and the study design in general was prospective, multi-center, randomized trial as well, using the Sapien XT second generation of the Sapien valves this time, and involving 2,032 patients, randomized equally to TAVI and surgical group, involving patients from different centers. And the study was conducted starting from 2011 to 2013 with a median with a duration of follow-up of 2 years. This was the target and the primary outcome, also which was the all-cause mortality or disabling stroke at 2 years. The inclusion criteria was similar to the Partner 1 with the change of involving patients with intermediate risk for operative complications rather than the patients who were inoperable or at high surgical risk. Exclusion criteria was also almost identical to the exclusion criteria in patients with Partner 1 trial. The intervention, patients were stratified in cohorts according to access route, either transfemoral or transthoracic. And also the transthoracic was either transaortic and transapical. Were then randomly assigned in a 1-to-1 ratio to undergo either transcatheter or surgical aortic valve replacement, the TAVI percutaneous placement, a tri-leaflet bovine valve with a stainless steel support frame deployed by balloon during rapid RV pacing. Heparin and other medications was continued this time. The aspirin clopidogrel for only 1 month at least, rather than the 6 months, which were continued in Sapien first generation valves. The surgical group, they underwent surgical aortic valve replacement with prosthetic valve. Again, the baseline characteristics for the patients in the two groups were generally equal, well balanced. Now, the primary outcome, which was the death from any cause or disabling stroke, which was compared in the surgical group versus TAVI. Again, here you can see that at 2 years interval, there was no significant difference in the rate of surgery of mortality and between the surgery and TAVR group. And also when they compare it this time, when they compared the transfemoral approach versus surgery, they have a slightly increased rate of death in the surgery group. They achieved like a p-value of 0.04. Okay, now, so we would like to compare the outcomes at 30 days interval. You can see here that the major vascular complications rate was much more higher in the TAVR group with a statistically significant difference of 0.008. The lack of retaining or disabling bleeding, the acute kidney injury, the new atrial fibrillation rate was much more higher in the surgery group in comparison to the TAVR group at 30 days interval. So for the secondary outcomes, TAVI and surgical aortic valve replacement resulted in similar rates of improvement in clinical heart failure, as well as echocardiographic valvular function. The aortic valve replacement included a 30% higher rate of major bleeding, 2% higher rate of acute kidney injury, and 16% higher rate of incident atrial fibrillation. A TAVI was associated with a 3% increase in major vascular complications. Here, they are comparing the aortic valve area at 2 years interval. So you can see here that the aortic valve area was much larger in the TAVR group after 2 years interval in comparison to the patients who underwent surgery with a significant difference. And then in comparing the symptoms, you can see that we have a lower rate or a better reduction of the symptoms in the patients who underwent surgery at 2 years interval in the surgery group in comparison to the patients who underwent TAVI. So as a conclusion, in patients with symptomatic severe aortic stenosis who are intermediate risk surgical candidates, TAVI was non-inferior to surgical aortic valve replacement with respect to all-cause mortality and disabling stroke at 2 years. The criticism, also the exclusion of the important population from this trial, including patients with coronary artery disease and reduced ejection fraction, inadequate or inappropriate time of follow-up for those patients. Also, the study operators and patients were not blinded, which may consider a risk of bias. And the result, the outcomes were assessed by blinded adjudicators. And although designed as a trial of intermediate risk patients, 12% of the study population had an STS score of more than 8, which is considered a high-risk patients. Also, it might create some kind of bias in the result. Now, lastly, I will discuss the Partner 3 trial, which was published with the title of Transcatheter Aortic Valve Replacement with a balloon expandable valve in low-risk patients. As background, previously, partner trials have shown that TAVR or TAVI was superior to standard therapy in extreme risk patients who were considered inoperable and non-inferior to surgery in high and intermediate risk patients with aortic stenosis. So the clinical question, Partner 3 trial, was in patients with symptomatic severe aortic stenosis who are at low risk surgical candidates with an estimated mortality of less than 4%. Is transcatheter aortic valve replacement non-inferior to surgical aortic valve replacement with respect to the primary composite outcome of death, stroke, or rehospitalization at 1 year? So again, they randomized the patient into two different groups involving 1,000 patients into a TAVI with using this time a Savian third generation valve and surgical valve replacement with prosthetic valve. The primary endpoint was, as we illustrated earlier, the composite of all-cause mortality, stroke, cardiovascular, rehospitalization at 1 year post-procedure. Secondary endpoints were also similar to the previous partner trials, included stroke, a composite of death or stroke and new onset of atrial fibrillation at 30 days interval, the length of the index hospitalization, poor treatment outcome, and analysis of change in the New York Heart Association, the symptoms in general. So the study design, it was also a multi-center randomized clinical trial involving 1,000 patients randomized equally into two groups, surgery and TAVR or TAVI, involving patients from different centers and all over the world. Different countries from all over the world. And the study was conducted from 2016 to 2017 with a median follow-up of 1 year. So the inclusion criteria was also similar to the previous inclusion criteria, with the difference this time that they involved low surgical risk patients with SCS score to predict mortality of less than 4%. And the exclusion criteria was also similar, with one difference, like they involved here the patients with ejection fraction of less than 30. And in the previous studies, they excluded the patients with ejection fraction of less than 20%. So the intervention, after the randomization to transfemoral TAVI with the Sapien 3 or third generation system versus surgical prosthetic aortic valve replacement, all TAVI procedures used the transfemoral route, and patients received aspirin and clopidogrel this time and were advised to continue taking these medications for at least 1 month. Similar to Partner 2 trial, and all patients underwent neurological exams at baseline, 30 days and 1 year also. So also again, the baseline characteristics in the two groups, the TAVR and surgery, was generally equal. The primary endpoint, you can see here that at 1 year, TAVR was associated with 6.6% absolute reduction in death, stroke, or rehospitalization. You can see here that at 12 months, you have the rate of death, stroke, or rehospitalization in the surgery group, which was equal to 15.1%, and in TAVR group, 8.5%. So the rate of death was higher in the surgery group with a statistically significant difference. Okay, now I'm going to explain each one of the primary endpoints separately. So at 1 year here, you can see the rate of the composite in comparison to the two groups was statistically significant. The rate of death was higher in surgery at 1 year interval and also at 2 years interval. The rate of death alone was also higher in the surgery group at 1 year, but without being statistically significant. And also it was higher in the surgery group without a statistically significant difference at 2 years interval. Stroke, it was also higher in the surgery group with a statistically significant difference by p-value of 0.03 at 2 years interval. Also, the rate of stroke was higher in surgery group without statistically significant difference. Rate of rehospitalization, also it was higher and statistically significant in the surgery group, but at 2 year interval, again, it was higher in the surgery group with 12.5% compared to 8.5% in the TAVR group. So the secondary outcomes, they were almost all higher in the surgery group, involving the new onset atrial fibrillation, the length and index hospitalization, death from any cause, the death or stroke, and also the stroke alone. Now comparing the secondary outcomes between the surgery and the TAVR group, you can see here like at an interval of 30 days, comparing the TAVR to surgery, the symptoms were reduced more in TAVR group at 30 days interval, and also but at 1 year interval, there was a pattern reduction in the surgery group, 16.7 compared to 17.7. 6-minute walk test and the Kansas score. At 1 year interval, you can see here that better results were achieved with TAVR at 6-minute walk test, and also at 1 year interval in the Kansas score, which indicates the physical ability of this patient in better condition. The score was higher in the TAVR group in comparison to the surgery group. Secondary endpoints, you can see here that the new left bundle branch block was much more higher at 1 year interval in the TAVR group in comparison to the surgery. Also, the valve thrombosis was also higher in the TAVR group with 1% in comparison to 0.2% in the surgery group. But without being statistically significant in the 1 year interval, but they achieved a statistically significant difference at 2 years interval regarding valve thrombosis. The main gradient, here you can see that the surgery, the gradient with patients who underwent surgery was lower than the patients who underwent TAVR at 2 years interval, with a statistically significant difference of a p-value of less than 0.001. Here, the aortic valve area, you can see that the aortic valve area at 2 years interval was almost similar, 1.7 to 1.7 in surgery and TAVI group. The paravalvular regurgitation at 2 years interval, again comparing TAVR to surgery, you can see that the rate of paravalvular regurgitation was lower, almost zero in the surgery group in comparison to 0.5% in TAVR group. Okay, so as a conclusion, in patients with symptomatic severe aortic stenosis or low-risk surgical candidates, TAVR was associated with a 6.6% absolute reduction in death, stroke, or rehospitalization at 1 year when compared to SAVR. The superiority of TAVR was driven by symmetric reductions in each component of the primary endpoint, including a 1.5% absolute reduction in overall mortality. Criticizing partner 3 trial, the outcomes adjudication was not blinded, as we indicated earlier. The results apply only to the defined trial population, and like the other partner trials, excluding an important population who might benefit from either surgery or TAVI. They were not studied or included in this trial. More patients in the surgery group than in the TAVR group withdrew from the trial, so they might create some sort of bias in the results. Missing data regarding secondary outcomes were not fully accounted for with multiple amputations, and also it might create some sort of bias in reporting the results. In this trial involving younger low-risk patients, the protocol requires clinical and echocardiographic follow-up to continue for at least 10 years, which indicates the need for a longer follow-up time. Now discussing the change and the guidelines, I tried, but I only find like a few things that I noticed that has been changed. But first of all, in 2014, the surgical AVR aortic valve replacement of low or intermediate risk for surgery, an indication for aortic valve replacement that considered class 1 level A. TAVI indication, there was an indication for TAVI, there was an indication for aortic valve replacement, but with a prohibitive risk for surgical aortic valve replacement and predicted post-TAVI survival of more than 1 year. TAVI was considered as a class 1 level P. And if you can take a look on the new guidelines, the class 1 level B now was a class 1 level A for symptomatic patients with severe aortic stenosis who are between the age group of 65 to 80 years and have no anatomic contraindications to transfemoral TAVI. Either SAVR or transfemoral TAVI is recommended after a shared decision-making about the balance between expected patient longevity and valve durability. The other guideline which has been changed for symptomatic patients with severe aortic stenosis or above 80 years of age or younger, patients with life expectancy of 10 years and have no anatomic contraindications to transfemoral TAVI. Transfemoral TAVI is recommended in preference to surgical aortic valve replacement, which is now considered a class 1 level A evidence. Thank you.
Thank you, Dr. Fatima, for this comprehensive presentation about partner and trials. Is there any question for Dr. Fatima? So it seems there is no question. So thank you again, Dr. Fatima, for this presentation.
You're most welcome.
So we can finish our session today because we only have this in partner trials. Thank you again, Dr. Fatima.
You're most welcome.